Welcome back to the deep dive. So, you've given us the sources on med-surg nursing for gynecologic problems, and today we're really aiming to unpack that.
Yes, focusing on the key pathophysiology, the risk factors you absolutely need to know, and of course, the critical nursing management pieces.
It's a unique area, isn't it? Because it's so tied to privacy, body image.
Deeply, and the chapter really grounds us in 5 core concepts first. The priorities are sexuality, infection, and pain.
Okay.
And then supporting those, you have elimination and reproduction.
That framing immediately tells you, look, this is sensitive stuff. Patients might not easily share about, say, abnormal discharge or pelvic pain.
Exactly. So creating that safe, non-judgmental space is, well, it's fundamental. The sources are clear.
Hmm.
Providing patient-centered sexual health care. That's a basic competency, even for new nurses.
You have to be able to get that history.
You really do. Otherwise, your assessment is incomplete.
Okay, let's dive into the first big example then, which really hits sexuality and reproduction. Uterine Leiomyoma, fibroids. What are we looking at pathologically?
Right, fibroids, they're incredibly common. Basically, benign, slow-growing, solid tumors. They come from the myometrium.
The muscle layer of the uterus.
Exactly, the muscle layer. And we know they're hormonally driven, likely responding to estrogen, progesterone, maybe even growth hormone.
I think visualizing where they grow is key for understanding symptoms. Can you walk us through the classifications? Figure 66.1 in the source, right?
Yes. Think of the uterine wall in layers. First, you have intramural fibroids. They're embedded right in the muscle wall. Makes the uterus feel large, bulky.
Okay, inside the wall itself.
Then there are submucosal fibroids. These push inward into the uterine cavity.
Ah, and that's why they often cause bleeding problems.
Precisely. They disrupt the lining, cause heavy bleeding, and can interfere with pregnancy. They're often the most symptomatic in terms of bleeding.
Makes sense. And the third type?
Subserosal. These grow outward, pushing through the outer surface of the uterus.
So they're the ones likely to press on other organs.
Exactly. They can press on the bladder, causing urinary frequency, or the bowel, leading to constipation. That pressure sensation often comes from subserosal fibroids.
Okay, so location dictates the main symptoms. Who's most at risk then?
The peak incidence is typically in the early 40s. And a really important point the source highlights is that the incidence is 2 to 3 times higher in Black women.
Right. That's a significant disparity.
It is. And while the exact why is still being researched, it means nurses need to be aware, avoid assumptions, ensure everyone gets equitable screening, and consider genetic factors in the history. Other risks include early menarche, high-red meat consumption, alcohol, hypertension.
So if a patient presents with, say, heavy bleeding, what are those key assessment cues we're looking for?
Well, the number one reason they seek care is usually that abnormal uterine bleeding, AUB, often heavy, maybe with clots, and painful periods, dysmenorrhea.
Beyond the bleeding.
Definitely ask about pelvic pressure or heaviness, pain during intercourse dyspareunia, and don't forget those elimination changes from the pressure constipation, urinary frequency, maybe even retention. You need to ask specifically.
Got it. So for diagnosis, the source points to transvaginal ultrasound as the main tool.
That's the diagnostic study of choice, yes. It gives a clear picture, but you'll also do some basic labs.
Like,
Well, hematocrit, obviously, to check for anemia if there's heavy bleeding, a TSH level to rule out thyroid causes of menstrual issues, and of course, a pregnancy test.
always rule out pregnancy.
Always. And if things are complex or there's a question of malignancy, an MRI can sometimes help differentiate.
Okay, let's talk management. If someone's asymptomatic or maybe heading into menopause, often it's just observation, right?
Often, yes.
Ah.
Watchful waiting. But if they are symptomatic, the path depends a lot on their future pregnancy plans.
Right. So if they still want the option of having children,
Then the goal is to spare the uterus. They might try hormonal management first, like oral contraceptives, to control bleeding. If surgery is needed, it's a myomectomy.
which is just removing the fibroids themselves.
Exactly. Removing the fibroids, leaving the uterus intact, laparoscopically or sometimes hysteroscopically.
But there's a really important consideration after myomectomy if they do get pregnant later.
Absolutely critical. The scarring on the uterus from the myomectomy significantly increases the risk of uterine rupture during labor.
Wow, okay.
So these women often need a planned C-section for any future births. That's vital patient education.
Definitely. Now, what about women who aren't planning future pregnancies? There's uterine artery embolization, UAE or UFE.
Right, UAE. This is a less invasive option done by interventional radiology. They go in through the femoral artery with a catheter.
Up into the uterine artery.
Yes, and they inject tiny pellets, polyvinyl alcohol pellets, usually to block the blood flow feeding the fibroids.
Starve the tumors, essentially.
Exactly. It causes the fibroid tissue to infarct, die off, and shrink.
Now, this brings us to a nursing safety priority in the source. That post-procedure period sounds intense.
It really can be. The action alert highlights that in the first 24 hours post-UAE, the patient can experience severe cramping.
Because the fibroid is dying. Necrosis.
Precisely. It's ischemic pain from tissue necrosis. It's often bad enough to require patient-controlled analgesia, a PCA pump.
So managing that pain is key, but what else are we watching for?
You're watching for post-embolization syndrome. That's like a systemic reaction fever, nausea, feeling generally unwell, malaise, needs close monitoring.
Okay. And then if other treatments don't work, or the fibroids are just too extensive?
Then the conversation often turns to hysterectomy. Total hysterectomy, removing the uterus and cervix, is actually a very common reason women undergo this surgery.
And this brings us right back to that sexuality concept we started with.
It really does. A crucial nursing role here is the psychological assessment before surgery. Losing the uterus can be a significant emotional event tied to self-image, femininity.
Grief, even.
Yes, a real sense of loss. And if the ovaries are also removed, the BSO part, bilateral salpingo-oophorectomy, then she's plunged into surgical menopause.
Meaning hot flashes, vaginal dryness.
Vaginal dryness, loss of libido, things that definitely impact sexuality. So discussing management options like local estrogen cream or lubricants is essential.
That leads us nicely into our next section, focusing on elimination. Pelvic Organ Prolapse, or POP. This sounds like a structural issue.
It is fundamentally a structural failure. The sling or hammock of muscles and connective tissue supporting the pelvic organs weakens or gets damaged.
What causes that weakening?
Several things. Neuromuscular damage from childbirth is a big one. Also, anything that chronically increases pressure inside the abdomen, pregnancy itself, obesity, chronic coughing, heavy lifting, and decreased estrogen after menopause plays a role too, weakening tissues.
And the most common type is uterine prolapse.
Uterine prolapse is very common, yes. But let's focus on the two types that directly impact elimination. First, the cystocele.
Bladder prolapse.
Exactly. The bladder bulges down through the anterior vaginal wall.
And the consequence of that is often urinary issues.
Yes. Stress, urinary incontinence, SUI, leaking urine when you cough, laugh, sneeze. And because the bladder might not empty completely, there's a higher risk of urinary tract infections, UTIs.
Okay, so cystocele connects directly to SUI and UTIs. What's the other main type affecting elimination?
That would be the rectocele. Here, the rectum bulges through the posterior vaginal wall.
Making bowel movements difficult.
Very difficult. Patients might report needing to splint, meaning they have to manually press on the perineum or inside the vagina to help empty their bowels.
So, assessment-wise, what are the key things to listen for, besides directly asking about SUI or bowel issues?
They might describe it vaguely, like a feeling of something falling out, or pelvic heaviness, maybe a dragging sensation. Sometimes a persistent low backache that feels better when they lie down.
And diagnosis is mainly clinical?
Primarily. A speculum exam, a bimanual exam. Doctors often use the POPQ system, pelvic organ prolapse quantification, to stage the severity.
Okay. Interventions. We usually start non-surgically.
Always try conservative first. Pelvic floor muscle exercises, PFMEs. Kegels are foundational, strengthening those support muscles.
Everyone should know how to do Kegels.
Absolutely. And then there's the vaginal pessary. It's a device, often a ring, inserted into the vagina to physically hold the organs up.
Like internal scaffolding.
Kind of, yes.
Yeah.
For rectocele specifically, management also focuses heavily on bowel routine, high-fiber diet, plenty of fluids, maybe stool softeners to avoid straining.
And if those don't cut it?
Then surgery becomes an option. Reconstructive procedures, sometimes combined with hysterectomy if the uterus is prolapsed too.
The source mentions specific repairs, colporrhaphy.
Yes, anterior colporrhaphy, or anterior repair, tightens the front wall for a cystocele. Posterior colporrhaphy, posterior repair, fixes the back wall for a rectocele.
And there's a really important action alert about mesh use here, right?
Crucial point. The FDA actually ordered manufacturers to stop selling surgical mesh specifically designed for transvaginal repair, POP, back in 2019.
Because of complications.
Yes, significant complications like pain, erosion, infection. So while mesh might still be used in other abdominal approaches, transvaginal mesh for POP repair is generally out in the U.S. Nurses need to know that.
Definitely current practice knowledge. What about post-op care after these repairs? What's the focus?
Okay, immediately post-op, they'll likely have a urinary catheter for about 24 hours. The big teaching points are all about avoiding strain on the repair.
Meaning?
No strenuous exercise, no heavy lifting. The usual limit is maybe 5 to 10 pounds, and no sexual intercourse for about 6 weeks, typically.
And something specific after the posterior repair for recticil.
Yes, after a posterior colporrhaphy, patients are often put on a low-residue or low-fiber diet for a short period.
That seems counterintuitive for bowel health.
It does, but the reason is mechanical. We want to decrease bowel movements initially, reduce stool bulk, and prevent straining to give those sutures on the back wall time to heal properly.
Ah, protecting the suture line. Makes sense.
It's temporary, then they transition back to high fiber.
Okay, let's shift gears now to the really serious conditions, gynecologic cancers. Starting with endometrial cancer, it's the most common.
It is the most common GYN malignancy, yes. But the good news, relatively speaking, is that it often grows slowly and is usually detected early because it causes noticeable symptoms.
Then the underlying pathophysiology.
It's strongly linked to prolonged exposure to estrogen without the balancing effect of progesterone. This unopposed estrogen leads to overgrowth of the uterine lining endometrial hyperplasia, which can become cancerous.
So the risk factors should line up with that estrogen exposure idea.
Can they do? Think things like early menarche, late menopause, more years of estrogen cycles, using estrogen therapy after menopause without progesterone, and conditions that increase estrogen, like obesity, type 2 diabetes, or PCOS.
Polycystic ovarian syndrome, right. And the key symptom that usually brings patients in.
Abnormal uterine bleeding, AUB.
Yep.
Crucially, any bleeding after menopause is a major red flag and needs investigation. They might also notice a watery, bloody vaginal discharge.
Treatment is mainly surgical.
Primarily surgical removal and staging. That typically means a total hysterectomy plus a BSO removing uterus, cervix, fallopian tubes, and ovaries.
Followed by?
Often followed by radiation therapy. Could be external beam radiation or brachytherapy.
Brachytherapy, that's internal radiation, right?
Yes, where radioactive sources are placed temporarily inside the body, close to the tumor site.
And there's a safety alert tied to that?
Yes, a best practice safety alert.
Right.
During the brachytherapy treatment session, which might only be 10-20 minutes, the patient has to remain on strict bed rest.
Why?
To prevent the radioactive implant from getting dislodged, it needs to stay exactly where it's placed for effective, safe treatment.
Okay, now let's contrast that with ovarian cancer. The source calls it the leading cause of GYN cancer death. It sounds much more aggressive.
It is, unfortunately. Ovarian cancer tumors tend to grow rapidly, spread quickly, and they're often bilateral, affecting both ovaries. The prognosis is often poor because it's usually diagnosed at a later stage.
And people often think of it as the silent killer.
That's a common misconception the source tries to correct. It's not truly silent, but the early symptoms are frustratingly vague and easily dismissed.
Like what?
Things like persistent bloating, feeling full quickly when eating, urinary changes like urgency or frequency, maybe some pelvic or abdominal pain. Women and sometimes doctors might chalk it up to GI issues or just aging.
So awareness of those subtle, persistent symptoms is key. What about risk factors? Is it also estrogen related?
Estrogen exposure is considered a risk factor, yes. But interestingly, things that reduce lifetime estrogen exposure or ovulation cycles, like pregnancy and using oral contraceptives, are actually protective against ovarian cancer.
That's different from endometrial.
It is. Key risk factors include middle to older age, never having children, nulliparity, a history of endometriosis, and importantly, carrying inherited mutations in the BRCA1 or BRCA2 genes.
Given its aggressiveness and high recurrence, I imagine treatment is pretty intensive.
Very much so. It usually involves major surgery, a TAH and BSO, plus lymph node dissection for staging and debulking.
Debulking, meaning removing as much visible tumor as possible.
Exactly, even if they can't get it all. That's followed by chemotherapy, often given both intravenously, IV, and directly into the abdominal cavity, intraperitoneally or IP.
And because it comes back so often?
Maintenance therapy is common. After initial chemo, patients might take drugs like PRP inhibitors, the source mentions Zejula, for example, to try and delay or prevent recurrence.
Okay, third cancer, cervical cancer. This one brings the infection concept right to the forefront.
Absolutely. The link is incredibly strong. Almost all cervical cancers are caused by persistent infection with specific high-risk strains of the human papillomavirus HPV.
Specifically types 16 and 18.
Those are the two main culprits, yes. They cause the vast majority of cases.
Which makes prevention pretty clear-cut then.
It really does. Number one is HPV vaccination, Gardasil 9, protects against the key high-risk types. And number two is following screening guidelines, regular pap tests, and HPV testing to catch abnormal cells early.
What if it does progress? What are the signs of invasive cancer?
Well, pre-invasive changes, dysplasia, are usually asymptomatic. That's why screening is vital. The classic symptom of invasive cervical cancer is painless vaginal bleeding, particularly bleeding after sexual intercourse, postcoital bleeding.
How is it diagnosed definitively?
If screening is abnormal, the next steps usually involve an HPV-typing DNA test to see if high-risk strains are present. Then a colposcopy.
What's involved there?
The provider uses a magnifying scope to examine the cervix, often after applying an acetic acid solution like vinegar, which makes abnormal areas turn white and easier to see. Then they'll take biopsies, like a punch biopsy or maybe a cone biopsy.
And for treatment, especially if preserving fertility is a goal.
For pre-invasive or very early-stage disease, there are minimally invasive options. Lead loop electrosurgical excision procedure is common.
What is LEAP?
It uses a thin, low-voltage electrified wire loop to cut away the affected cervical tissue. It's both diagnostic, providing tissue for analysis, and therapeutic. Cryosurgery, freezing, and laser ablation are other options.
And if a woman wants to preserve her uterus?
For certain stages of early invasive cancer, a radical trachelectomy is an option. It removes the cervix, upper vagina, and lymph nodes, but leaves the body of the uterus intact, allowing for potential future pregnancy, often requiring a C-section delivery later.
What about self-care after these ablation procedures like LEAP?
Key instructions focus on healing and preventing infection. Usually that means refraining from sexual intercourse, not using tampons, and no douching for a prescribed period, often around 3 weeks, sometimes longer. Follow the specific instructions given.
Got it. Let's quickly cover our last section. Inflammation issues, starting with vulvovaginitis.
Right. This is basically inflammation of the vulva and vagina. It's often due to a disturbance in the normal hormonal balance or the vaginal flora.
Not always sexually transmitted, right?
Not at all. The source highlights non-STI causes nurses should consider. Yeast infections, candidiasis, irritation from chemicals, think spermicides, feminine hygiene sprays, even harsh laundry detergents. And certain habits, wearing tight, non-breathable clothing, or wiping from back to front after using the toilet, which can introduce bacteria.
So prevention teaching is mostly about hygiene and clothing.
A lot of it is. Wear cotton underwear. Use mild, fragrance-free detergents. Clean the external vulva labia with just water. Avoid harsh soaps. And a big one, do not douche and avoid those feminine hygiene sprays. They disrupt the natural balance.
Okay. And finally, toxic shock syndrome, TSS. This sounds like a true emergency.
It absolutely is, potentially fatal. It typically results from toxins produced by bacteria, usually Staphylococcus aureus, sometimes group A strep.
And the connection is often tampon use.
Yes, leaving a tampon, particularly a highly absorbent one, in place for too long creates an environment where bacteria can multiply rapidly in the menstrual blood. The bacteria release exotoxins that get absorbed into the bloodstream. It can also happen with contraceptive sponges or diaphragms left in too long.
What are the hallmark signs? It develops quickly, right?
Yes, usually within about 5 days of the start of menses. Look for a sudden onset of high fever, a diffuse macular rash, often described as looking like a sunburn, muscle aches, myalgias, vomiting, diarrhea, and critically, a drop in blood pressure, hypotension, which can lead to shock.
So prevention is paramount. What are the key teaching points?
Change tampons frequently. Every 3 to 6 hours is the recommendation. Don't use superabsorbent tampons if you don't need them. Maybe use pads at night instead of tampons. Be mindful of time limits for diaphragms or sponges.
And if symptoms appear?
Seek medical help immediately. Tell them you have your period and are using tampons or another device. Treatment involves removing the source, like the tampon, aggressive fluid resuscitation, IV antibiotics, and potentially medications to support blood pressure. So wrapping this all up, you can see how we journeyed from, say, benign structural issues like fibroids and POP through potentially deadly cancers and touched on acute infections like TSS. The common thread is the nurse needing sharp assessment skills across all those core concepts: sexuality, infection, pain, elimination, reproduction.
Yeah, recognizing subtle cues, understanding the underlying pathophysiology, whether it's hormonal, structural, infectious, and connecting it all back to the patient experience.
And that patient experience links back to where we started: sexuality, and the profound impact these conditions and their treatments can have.
Right, which brings us to that final provocative thought from the source material. It's about looking beyond the immediate recovery.
Exactly. It emphasizes that the psychosocial impact, things like grief over hysterectomy, body image changes, anxiety about sexual function, isn't just immediate. It can surface months, even years later, even if the surgery was successful or the cancer is cured,
Even if ovaries are preserved.
even then. So the final takeaway for you listening is that proactive, ongoing assessment of psychosocial well-being is non-negotiable. We need to ask about these things long-term and be ready to refer patients to counseling or support groups as needed. It's a crucial part of holistic gynecologic care.
That long-term view of psychosocial integrity is absolutely key. Thank you for walking us through this incredibly important chapter. We hope this deep dive helps you integrate these concepts into your practice.
Thanks for listening.